Hello and good afternoon, everybody. I think we can start now, and the remaining participants will keep joining. Before we start, I would like to introduce Dr. Samar. So Dr. Samar did his MCH from SMS Hospital, Jaipur. He's going to be going to for a fellowship in breast reconstruction in Chelmsford in the UK. He has presented papers in national and international conferences. Till now, he has 10 published articles, which are PubMed Index. He's the ambassador for the APS journal and a resident advisory board member for the PRS journal. He also loves to play guitar, paint oil and watercolors, tennis, as well as trekking. Dr. Samar Gupta, it's a pleasure to have you here. Thank you for joining us today. Before we begin with the session, I would just like to remind the participants of some rules. Please keep yourselves muted throughout the session, and if possible, try to keep your cameras off. If you have any questions, you can put them in the chat box. So I think we're good to go now. Dr. Samar, you can take over.
Hello, everybody. First of all, thank you, Rupali, for such a great introduction. And I want to thank this team, this wonderful team, for giving this opportunity for me to present my work and my experience with the free fibula flap for mandibular reconstruction. And I hope it'll be a good lesson for all the listeners, the young doctors and the medical students. So I will be talking about free fibula for mandibular reconstruction, and I'm thankful to my mentor and chief, Dr. Pradeep Goel, for this particular presentation, and he has been an immense support for me to make this study and paper. So today's presentation is all about free fibula flap. What is a flap? What is free fibula flap? Its surgical anatomy, indications, our journey so far with this particular flap, and what are the lessons learned. Now, I'm aware that most of you do not have a very good intense exposure with the field of plastic surgery, and this is going to be very new for all of us. I'll try to make it very simple, and in a way that you will actually get this sense of what reconstruction in plastic surgery is, specifically in the head and neck region. You must be exposed to cancers in ENT rotations, commando surgeries, but what we are not usually exposed to, especially in the tier 2 and tier 3 cities, is the reconstruction aspect of this particular field. So the free fibula flap is the fibula bone in human body is something like, it does not have a major function. It does support the ankle, it does support the leg, the tibia bone for weight bearing, but if you remove the fibula, it doesn't really kind of affect the function of walking. The patient can walk, the patient can run, as he usually did when he had the fibula bone there. So Taylor, in his first paper, and this is a beautiful paper, you must go to Plastic and Reconstructive Surgery Journal, published in 1975, the use of the free fibula flap. Now, just for starters, what is a free, what is fibula, and what is a flap? So flap is nothing but a piece of tissue that is taken from one place to another along with its vascular supply. So what we are doing up here is we're using one part of the tissue, and we are kind of removing that from that particular part position and keeping it at some other area that where we need it. What is free? So free is like you take the tissue along with its vascular supply, the nerve supply, and you reposit it at somewhere else, some place else in the body, and we kind of anastomose the artery and the vein so that the vascular supply of that particular flap is maintained. So that is free. And fibula, because it's fibula bone, and flap is a flap. So he described this particular flap for limb reconstruction, like long bone defects, like tibia defects, patient in which the tibia is gone. It's kind of, it can be absent and damaged due to trauma, due to cancer, due to sarcomas, and you reconstruct it using the fibula. The fibula bone then acts as a weight-bearing bone in that particular leg. But for mandibular defect, Hidalgo was the first one to use fibula, and today the free fibula bone the flap is the gold standard for mandibular reconstruction. And this is an excellent paper from Sloan Kettering, and I happened to be there last month at Sloan Kettering. This particular person, Dr. Hidalgo, is a pioneer in this particular field. And recently he switched his practice from reconstruction to aesthetic for the last last decade. So what is a free fibula flap and where does it derive its vascular supply? The vascular supply, as you can see in this diagram, comes from peroneal artery. Peroneal artery comes from the popliteal artery. Now, what we're doing is we are going to take the part of the fibula, and you can see it's covered via muscle cuff, the FHL muscle, the flexor hallucis longus, and the skin island, which also derives its supply from a perforator that arises from peroneal artery. So the bone, the muscle, and the skin island is based on peroneal artery and vein, and we harvest this flap on this particular vascular pedicle. So I won't go on to the detail of dissection because that will make this particular talk very complicated. But yes, as you can see in this figure, skin has been elevated in superficial manner, and then we kind of using along with the skin, we will be taking out part of the bone. We'll be discarding the upper end and the lower end. We do preserve a little bit of the lower end to stabilize the ankle and the upper end to prevent damage to the nerve. And then once the bone is harvested and along with the skin and muscle, it looks something like this. Now you can see in this figure that the surgeon is holding this flap with the bone, the skin pedal, and the neurovascular pedicle that's going on the upper portion of the leg. So you can harvest this flap in a multiple, like, you can harvest it as bone, you can harvest it as also cutaneous, along with some muscle, because you have to do sometimes a lot of the cancer has been removed from the face, and you have to fill this gap. This you can fill it with the soleus muscle. So this is a complete spectrum of the fibula of ossicutaneous flap. You can see the peroneal vessels that is going towards the neomandible. Neomandible is nothing but a reconstructed part of the fibula into the mandible form. You can also see the skin cover, skin pedal that's there. In this, there are two skin covers. You can see the upper one, which is the bigger one, and the lower one, the distal skin for the reconstruction of inner and outer table. So indications of free fibula, there are many: mandible, maxilla, long bones, metacarpals, metatarsals, penis reconstruction. Most commonly, the mandible for mandibular reconstruction, head and neck. In the head and neck region, the free fibula is being utilized. Such are the patients where we have these kind of huge defects. In this patient, you can see the entire lateral part of the mandible is gone. And for mandible reconstruction, free fibula is the gold standard. In head and neck cases, CA buccal mucosa is the most common cause where we have to employ this particular flap, and it usually causes lateral mandibular defects. In this patient, we can see that this white leukoplakic plaque, including the CA buccal mucosa squamous cell carcinoma. And in this particular patient, you can see that the defect that will be formed. Defect basically means what is the residual area after excision. And and these red lines they denote the skin markings by which you can also complete the neck dissection. Usually the resection part is done by the oncologists. It can be surgical oncosurgeons, and they could be ENT surgeons as well. Plastic surgeons usually called after the excision, where we perform reconstruction based on whatever the requirement is going to be. So in this patient, as I said, that you can see the buccal mucosal lining along with the mandible will be removed, and this will form by the fibular bone. You can see the fibular bone is marked. The red denotes the skin pedal, that is skin pedal which will be turned inside the oral cavity and used for mucosal lining. So in this particular patient, you will have the fibular bone as well as the mucosal lining for reconstruction. And this, you can see that how his mandible has been reconstructed using the fibular bone as well as the skin pedal. There's another patient where the mandible has been reconstructed using fibular bone. The contralateral fibula bone was used, and the skin pedal was used to cover both the lining and the cover. Cover means the skin part, and lining means the inner mucosal part. And this is a post-operative picture of the same patient. This is another patient where the central arch, this segment between in the central portion of the mandible, between the canines, and this was used for, again, for both lining and cover in this particular patient. And these are the operative outcomes. You also get some kind of big tumors sometimes, and you really have to use multiple modalities to cover these particular kind of patients. And I will show where a large 3D defect can be covered by both a free flap as well as a local flap. Now, as I said, the free flap is a flap that is harvested along with its by cutting its vascular supply, and then it's reanastomosed to the adjoining area. For example, the common pivotal artery would be anastomosed to some vessel in the neck. It could be the external carotid, it could be the common facial artery, and drain into the IJV or any kinds of the tributaries of the internal jugular vein. Sometimes you also use true free flaps, but only when the patient's characteristics allow, because using true free flaps is actually very, very complicated, because you need two donor vessels, you need two recipient veins, and you also need two donor flap areas. In this particular patient, you can see it's a large defect. You would have his entire mandible on the side removed, along with the skin as well as the inner mucosal lining. And this cannot be fulfilled by one single flap. So we'll use two flaps. In this particular patient, we use the fibula flap in the contralateral leg, and the skin pedal of the fibula flap, as you can see in this oval structure that is marked up here on the leg, is used to cover the inner lining. And for the cover, the PMMC flap, the pec major flap, which is harvested from the chest. And this is a local flap because we do not cut the vessel, we just directly rotate it from the chest area on the face wherever it's required. You can see the PMMC is marked by a white arrow on the middle picture. This is the outer island, and it has been taken from the person's right chest. The fibula on the on this other side has been used to reconstruct the mandible, but also the inner mucosal surface. In this particular patient, the deltopectoral flap was used along with the free fibula. Free fibula again for the lining, and the deltopectoral flap was used for the cover. Now, I said that, sometimes you do use two free flaps. For example, in this patient, the free fibula flap was used for the inner lining and the mandible, but the radial forearm flap was used to make the lip. It wasn't possible to make the lip from one single free fibula, because this, you can see, it's a 22 by 10 centimeter skin island. This is a huge skin island, and it's probably the largest skin island that we've used in our experience. So apart from the head and neck cancers, we do have some kind of benign tumors that are mostly ameloblastomas, where we can actually go for immediate reconstruction as well as delayed reconstruction. But we always prefer immediate reconstruction because it allows us to also integrate the implant. So along with, whenever we are making the mandible out of the fibula, we actually insert dental implants at that point of time. So the patient, when he comes out of surgery, not only does he have a good aesthetic outcome because he has a new mandible, but also a good functional outcome because he can almost begin to start eating after a few days. So he doesn't, normally what we do is we will create the mandible and we'll put the dental implants after a few weeks or months. But in benign tumors like ameloblastomas, we can do it in the first setting. So one stage, you have everything. So this is a young patient came with ameloblastoma. You can see a big swelling on the chin area and in the floor of the mouth. So entire floor of the mouth, is central segment as well as the lateral segments were extracted, and you can see how almost the entire the central segment and the body part of the mandible has been resected and reconstructed using the free fibula flap. And you can see these green mini plates which are used to contour and kind of create angulations of the reconstructed mandible. And this is how you place it and attach it to the residual mandible. In this particular patient, the ramus of the mandible was preserved, and we used two osteotomies. Osteotomies means you cut the bones to create these kind of angles. And this is a good outcome of this particular patient, and that the scar line is relatively hidden in the neck crease region. So, what is the latest in the field of head and neck reconstruction? It is 3D printing and CAD/CAM technology. Now, CAD/CAM, computer-aided design and manufacturing, has been in use for the last decade, almost a decade, and it's utilized very commonly in many centers. In India, it is something that has come up recently in the last few years, and we at SMS Hospital Jaipur have started this 3D printing technology at a very low cost methodology, because it just uses free computer softwares and a 3D printer. So what it does, it actually reduces operative time. It helps in better pre-operative planning, and I'll show you how it makes easy for residents to plan and learn the trade quickly. So I'll deal with this particular patient. You can see that his entire mandible has been eaten by the ameloblastoma. He has this huge swelling in the chin area, and we created these 3D lithographic models. These are 3D printed models. They're derived from the 3D CD scan, a normal CD scan that costs around $1,000 in the government sector. The CD is obtained, given to the 3D printer manufacturers, and they will give us this print like this. And you can see how we can actually understand where the resection can be done. In this particular patient, you can see that there's a blue vertical line where this line has been used to cut the tumor. So only the condyle part and half the ramus vertically will be left behind, and the rest of the part of the mantle will be taken out. Now, this is very essential because for residents and for young surgeons and for even medical students, you can actually understand how much part of the mandible is actually needed to reconstruct from the fibular bone. So you can see, for virtual 3D planning, we can see this particular image in the computer, and this is a mesh mixer software, and you can make the plane of resection. So once you make the plane of resection on both the sides and remove the tumor, you will get the residual mandible. This is the colored part, which will be resecting the segment virtually, and just got it removed. So after removing, what we need to reconstruct the mandible. You can see how the mandible is reconstructed over a superimposed image of the normal mandible. And once you do the superimposition, these are the blocks that will be created by the fibular flap. So in this manner, you can actually get to know what are the lengths required from the fibular bone for each of these segments, and what are the angulations, because when you're making angulations, you're kind of removing a wedge. So the angulation would depend on how much the wedge is going to be removed. So the entire length will also be determined by a manner in which you need to understand what are the angulations, how much of the tumor is actually resected to create a requirement of the mandible, and then you can get the entire length of the fibula that you need for reconstruction. So in this particular patient, we can see that this is a huge, almost around, I think, 20 centimeters of the fibular bone is being utilized in this particular patient, and used to create this three-dimensional structure of the neomandible. And this particular skin island, you can see, is being used to cover the inner mucosal surface. The outer skin is pretty much normal in this patient. And these are the post-operative outcomes. And we've also presented and published this paper in the British Journal of Plastic Surgery, that is JPRAS. And you can read this paper online. Basically, it gives how you can make this particular technology low cost and easy and reproducible for a center like ours, a government center. And you can also check out the video of this if all of you are interested to check out the videos of how to harvest free fibula flaps. We have an entire series of this on the particular channel that is presented in this slide. Go to this YouTube channel and check out how this flap is harvested in a step-by-step manner, describing the technique of free fibula flap. Coming down to complications, well, flap failure occurs in around 3% of the patients, and it's very difficult for us to manage these particular kind of patients because not only just not only is just a flap failure, it also it kind of causes a donor site morbidity. So the patient lands up in a situation where he has a defect, he has a wound in his face, and now he also has a lost fibula bone. So it's not very much acceptable, but still in the reported incidents and even in our series, we have a 3% failure rate. So once you fail, what do? You kind of re-explore the patient, because a failure will result either from a blockage in the artery, a blockage in the vein. So whenever there's a blockage in the artery, usually presents early, like, you do the surgery, complete the surgery at 3 p.m. in the afternoon. And you see by 4 o'clock when you're monitoring these particular kind of patients. So after surgeries, you are supposed to monitor these patients. Monitor is you'll see whether the flap is healthy or not. You kind of make a slight scratch on the skin paddle, and you see if the blood is oozing out. Blood is oozing well, fresh, bright red, it's good. But if it's dark, dusky, it's kind of congested. If there is no blood, that means there's an arterial block. So in the initial few hours, there's a high incidence of an arterial block. And arterial blocks generally occur because of thrombus formation. And thrombus, when it forms, it will reduce the supply to the flap. And you will see when you test by scratching the flap, there'll be no blood flow. So immediate exploration is the key, because if you do not re-explore early, the toxic substances will accumulate and the flap will die, and you cannot revascularize the flap. And not only this, flap failure could also occur due to a tight bandage. And now it's very funny that such patients that you actually find that because of tight bandage, there's kind of pressure on the vascular pedal. You need to prevent this, and you need to train the residents and the staff to prevent this particular thing to happen. And you could also have a kinking vessel, like if there's a vessel that has kinked, kind of made an angulation, then you reduce supply to the blood and it will cause flap failure. As soon as you observe this, you take the patient straight to the OT. You will see that you'll explore the anastomosis area. You will see whether the artery is blocked, the vein is blocked. You will cut and you will redo the anastomosis. That's the best possible way to manage this particular kind of complication. So earlier the intervention, the better the results. You will succeed if you are going to re-explore the patient in an hour. The longer you wait, the worse the outcome will be. Okay, so once you re-explore, but still the patient lands up in thrombosis or whatever the ischemic injury, and the patient turns up into flap necrosis. Now what to do? Patient has a defect, the cancer is gone, but now he has also had defect. The donor site morbidity is there. So you can either go for the local regional flap, like a major flap, or the DP flap. These are very safe flaps with almost 100% success rates. Or you could go for a secondary flap. Now, secondary flap is actually it's very crucial to know whether you should go for a secondary flap or not. In a very selected few patients where the patient is healthy and there are no complications, patient is young with no comorbidities, and in the right frame of time post-op, like if the patient is within a week of flap failure, it's okay to do a free flap. This is slightly complicated, and we have actually conducted this study, and we presented the study in this year's plastic surgery, the meeting held at Atlanta, which basically talks about secondary reconstruction in free flap failures and head and neck cancers. Still writing this, and we're going to be publishing this entire manuscript in one of these journals, hopefully. But yes, it's a good study, and this basically tells us what to do once a free flap fails. More on that will be coming up later. So every activity is worth doing, especially in surgeries, has a learning curve. And each surgery is going to teach you to learn from the mistakes and become better. It's not a one-day process. It's not a month process. It's a huge journey. And you will be learning new steps and new innovations. You'll be coming up with new innovations throughout your career. Surgery is an interesting field, and plastic surgery is awesome. Thank you very much for allowing me to present my work. I hope this has kind of created an interest in all of you. in this field of plastics, wonderful field of plastic surgery. And it was lovely to be presenting. And thank you so much for this opportunity.
Thank you so much, Dr. Samant. We have a question in the chat box. Kenneth has asked, why do we go for the contralateral leg to harvest the flap?
Okay, so this is actually a very, very good question. In today's consensus, you can take any leg. In fact, it's better to take the non-dominant or the left leg actually, because it helps in driving. Whenever the patient is, he can actually drive, and it doesn't have to kind of work, especially in automatic cars. This is the Western literature. So we usually take the left leg, but contralateral leg actually depends on the older consensus. And what we actually follow is that, whenever there is a vessel up here, like for example, you are reconstructing right part of the mandible, and the vessel orientation will be like this. So the contralateral leg would suit actually better in the orientation of the vessels, the peroneal artery, when you anastomosis, because you don't want kinking and you want an adequate length also. So if you're doing an ipsilateral anastomosis and an inner pedal and a mandible, this leg would be useful. But if you're doing it on the contralateral side, the anastomosis, the opposite leg will be useful. So it's kind of complicated to really understand. You'll have to go into more details on how the orientation sits. And there are a few, read this article in the Indian Journal of Plastic Surgery that has been published by Amrita Institute, I guess. They have kind of made you understand how to choose which leg and which vessel for mandibular reconstruction.
Thank you so much. So before we end the session, I think we can take a photograph. So the participants can turn on their video if you would like, and we can take a quick photograph. Okay. 1, 2, 3, go. That's it. Thank you so much, Dr. Samant. Your presentation was wonderful, and we learned a lot right from the anatomy to the complications. And we hope that our participants enjoyed it as well, and will definitely be taking up plastic surgery in the future.
Oh, I'm so glad to know that. Thank you.
Yeah, thank you so much.
Yeah.
We will be ending the session here. Thank you for attending, everyone, and you can move on to the next one. Thank you.